What are you going to do? What's your protocol say? Do you have a protocol that says to do something?
Yeah. CPR.
Let it go. Definitive care.
All right. So let's pack this patient up. Let's get him into the truck, and let's do everything en route. Folks heard that. A lot of head shaking. That's how I was taught. And that's how I taught a bunch of folks years ago. Load and go. Do everything in scene. We used to train to do IVs in the truck movement for entry certification. So during transport, patient arrest, you're about 5 minutes out from the hospital. You decide we're going to do CPR, continue on to the hospital, and you get them into the ED, and lo and behold, patient succumbs. Cardiac arrest. Doesn't get it.
This was a real case that we had in our county. I mean, the crew, I think they may have gotten the blood pressure like 50s, 60s. They tried access once, said, oh, I can't get access, so I need to start moving. And, well, not unexpectedly, the patient dies.
Yep. Unfortunately, we just had 3 days ago a very similar case. So, objectives for today. We want to define SADS. We want to talk about the pathophysiology that's holding up SADS and making sudden ambulance death syndrome. Look at the literature, look at the research, and then give you some tools, give you some implementation of protocols or policies to help you prevent SADS from occurring for your patients. So, who's heard of SADS before? Yeah, we just looked on the internet just a half hour ago. I was like, oh, some of our stuff has already been out there. Other people are using it. That's cool. But anyway, SADS is sudden ambulance death syndrome, right? And so, any of these things look familiar to some of y'all? Some of you guys are my age. So, what did EMS, the old mantra was, SADS, sudden ambulance death syndrome, occurred. We used to just take the mortuary cot out, load the patient on board, slide them in. We got fancy putting headlights on the hearse. And we just diesel bowls to definitive care. Up until about the mid-early 80s, we got fancy. Put some Q sirens on the fenders, some bubble lights on there, and boy, that 4-barrel carburetor would smoke down the road. And that was fun. Everything was very sloshy. But again, who's in the back of the patient? Well, we realized at that point in the 80s, right? I squeezed my derriere in the back there, but it's like, maybe you might be able to bag them, but that's really about it. And that's if I could pick somebody else up that would drive, or otherwise I'm just driving them up. And our drives were not in urban setting. They were 35 minutes to 45 minutes to up to an hour and a half to get to a physician. And so traditionally, trauma is load and go. Cardiac arrest now is stay and play. Right? We make a big difference staying in play. But what about this? What causes sudden ambulance death syndrome? So we still have policies, mantras, education components that still are pointing us in the direction of let's get the patient to definitive care. We load them up in a stretcher, and then they could. They could while we're going down the steps, they could while we're getting to the truck. Because we still have that old mantra still buried in the back of our head. Man, this patient's really sick, and you might get new paramedics, you might have old paramedics, it doesn't matter. Diesel bolus fixes everything. That's a lot.
Steve, I think there's also this idea of a comfort zone. People feel comfortable in the back of the ambulance. They don't feel comfortable in someone's home.
Yep. And also, too, what else do we have? We have a public expectation of we're moving. Right? Why aren't we going? Why aren't you taking my loved one to the hospital? We face that problem with cardiac arrest. We can face it with medical patients as well. So this is Dr. Ennis from New York. This is out of one of their education materials years ago. And they tried to identify what were some of the stable, unstable type patients, sick, not sick. And you can see at the bottom here, that thing, rapid assessment, transport as soon as possible. Nothing in there about taking care of the critical things at all. And so this has just been the mantra, the dogma that's existed still exists today. I mean, we still have this in our system going on. These calls still happen today. And it just takes a while to get folks to change. So we Googled, what is about EMS and rapid transport to definitive care? Well, the goal is to get patients, this is kind of the AI Google overview. The goal is to get patients to definitive care as quick as possible without minimizing delays.
That one struck a nerve with me. This is so drilled into our head that we need to load and go that even AI picked up on, hey, this is the standard of care.
Now we have to train models to not do that, right? So where did it originate? Well, SADS originated in 2019. Dr. Abraham presented a abstract at NMSP where she had identified in her shop some critically ill patients. They deteriorated on the way to the ambulance. And she had her folks stabilized on scene before you moved.
I think she was actually commenting on Vitiliani's. I think Veer presented this at AMSP, but this was like the first digital footprint when you look up SADS, the first time it was ever mentioned on the internet.
So why does this happen?
All right, so let's talk about the potential pathophysiology behind SADS. Anyone in the room know this guy? Anyone from Maryland? So Jeff Nussbaum, he is University of Maryland. He's a medical director for Baltimore County EMS, Baltimore County Fire Department. I think he did fellowship at Pittsburgh. But he gave a great presentation to his crews talking about the potential pathophysiology behind SADS. So let's talk about it, see what he proposed. Well, first, he proposed that when we come across a critical patient, maybe they're splinting themselves in whatever way maximizes their physiology. So maximizes their respiratory parameters, maximizes their preload, maximizes their afterload, and when we go to move them, we have interfered with the body's natural ability to improve its physiology, and they decompensate. I can see this, it seems pretty plausible. I can see that playing a role in SADS. Next, he says, well, maybe it's like crush syndrome. When we go to move a critical patient, there's release of toxic metabolites, and the patient decompensates and codes. All right, this one maybe seems a little more far-fetched, but I could still kind of see it. It says also maybe it has to do with catecholamines. When we go to move a patient, either there's a surge of catecholamines or a decrease in catecholamines causing the patient to code or decompensate. Okay, it also seems a little bit far-fetched, but I could kind of see it. I can guarantee, though, for the hypoxic patients, it has something to do with this, the oxygen hemoglobin dissociation curve. Has everyone in the room seen this curve? The main idea is that once you drop below those low 90s, your SpO2 plummets. Anyone who has failed an RSI has lived this curve, and the pucker factor associated with it, because the SpO2 will be 90, then 80, then 40, then 10, and the heart rate's 10, and the patient's coding in a matter of seconds. So when we don't treat hypoxia, the patient can just fall off that curve and die. I can also guarantee that has something to do with this. It always takes longer to move the patient to the ambulance than we expect. When we look at the stroke literature, stable patients who just need a ride to the hospital as soon as possible, 15 minutes average time to take them to the ambulance, 15 minutes on scene time average. So it always takes longer than we think it's going to take to move the patient to the hospital or move the patient to the ambulance, and during that time the patient can decompensate. I mean, you all can imagine a situation where you're moving a patient down 4 flights of stairs, you get to the ambulance, it took 20 minutes to move the patient down to the ambulance, and the patient's pulseless. You found the patient has no pulse. And you have no idea when in that 20 minutes the patient has coded. Well, now you've missed an opportunity to intervene on that patient, prevent them from coding in the first place, or have any sort of meaningful neurologic outcome for this patient. So it always takes longer than you expect to move the patient to the ambulance. So what do we know so far about SADS? What does the literature say and the research say so far? Well, there's not a ton out there. There are a few studies that were presented as abstracts. We're going to talk about, there was only one peer-reviewed publication. We'll talk about that as well. QR code takes you to some of our resources. But let's talk briefly about some of these studies. So first, dating back to 2017, the folks from Pittsburgh talked about PARCA. So PARCA is essentially a synonym for SADS, post-arrival respiratory cardiac arrest. And what they did is they did an education exercise for their crews. And what they found is by doing so, their incidence of PARCA or SADS decreased. So it went from 5.7 to 4%. Okay? So education probably helps prevent SADS. Okay? That's good. Next study from 2019 that they talked about at the NEMSP meeting, again from the folks at Pittsburgh, talked about crashing patient bundles. So they implemented a crashing patient bundle. We'll talk about these a little bit more later on. Essentially, the gist of the crashing patient bundles is that you resuscitate the patient where they lay, you don't move them until they're resuscitated. And what they find? Well, by implementing a crashing patient bundle, their incidence of EMS witness arrest dropped, or was cut in half. It's actually more than half, so 12.1% to 5.8%. So okay, crashing patient bundles probably make a difference. Next, in 2020, Vera Vidalani, the group from MedStar down in Fort Worth, talked about their SADS cases in their agency, and they identified 30 cases of SADS. And the main take-home point here is that most were respiratory in nature. So almost half were respiratory in nature. Only 6.67% had an SpO2 greater than 90 upon EMS arrival, and not much better when they went to move the patient, 10%. And 73% had delayed ventilation. Okay, so small study, just a case series, but okay, most of the cases were due to respiratory causes. Next, Dr. Inez from Buffalo gave a great talk at the 2021 NEMSP. I love her title here. High flow diesel fixes everything and other lies they told us in paramedic school. She gave a great talk, but she talked about their PARCA data and the instance of PARCA in their agency. And essentially what they found is that if you had an EMS witness arrest, your survival was dependent on how many interventions the paramedic did before you coded. So if you had more interventions done before you coded, the higher your chance of survival. So people who had more early interventions had a 17.8% chance of survival compared to patients who had only later interventions or fewer interventions, 8.7%. So okay, that kind of makes sense. If you have more interventions, you've gotten access, you've gotten fluids, you've gotten pressure on board, you're less behind the 8 ball when the patient loses a pulse. Kind of makes sense. Okay, so it just adds to the literature saying that early intervention makes a difference. The only actually published paper that has to do with SADS was this paper published by the folks from Buffalo in 2022 in PEC. They looked at the EMS modified early warning score, EMUs. Essentially, that's just a count of how many abnormal vital signs you have. And what they found is more abnormal vital signs, the higher your chance of having an EMS witness arrest, right? No surprise there. But if you had no abnormal vital signs, your chance of coding was 3.3 per 1,000. If you had 4 abnormal vital signs, 55.4 per 1,000. So okay, we can maybe predict what patients are going to have an EMS witness arrest or be at risk for SADS. So take-home points kind of from the literature, what little we have out there. Okay, education probably decreases SADS. Crashing patient bundles probably decrease SADS. Most SADS cases are respiratory in nature. Early intervention increases your chance of survival if you do have an instance of SADS or EMS witness arrest. And we can probably predict patients at risk for SADS just by looking at their vital signs. No surprise there. But I'm going to turn it over to Steve to talk about a more recent study, some more recent data that we looked at ECU regarding SADS.
Thanks. All right. So how many people have seen some of the stuff that's out there already that we've done? Okay, this is new. Okay. Now, so our first data set that we looked at, which you're familiar with, is 8.3 million calls that we did in 2019. Excuse me. The only issue we had with that, we had some concerns in 2019, what was going on. COVID, respiratory, right? So, like a good researcher, I just couldn't hack that. So I went and redid our stuff with 2021 ESO data. And so we pulled in another 11 million records. So we really looked at now 19.3 million records. So we're focused on 911 calls with paramedic on board, 18 years of age or older, critical vital signs, excluded trauma, excluded pregnancy. And so our critical vitals were SpO2 and SBP less than 90, heart rate less than 60 or greater than equal to 120, and then respiratory rates 4 to 8, and then greater than 20. So either slow or fast for respiratory. So we plugged that into a regression model. So we had age, race, white, non-white, the vital signs, high, low, heart rate, high, low, respiratory rate, and then our time to our first intervention. First intervention document. We also excluded, due to the capacity of the monitors to be accurate, and because we couldn't tell from the data whether the patient had pre-arrested, we tried to be a little bit conservative and not take some of those patients and throw some of the patients out that had blood pressures less than 20 initially, respiratory rates less than 4, SpO2s less than 30, and heart rates less than 20. And this goes on with the manufacturers, Physio and Zols. So time to first interventions, this is not an all-inclusive list, but we looked at all airway interventions, O2, BBM, CPAP and IPPV, NEBs, advanced airways, basic airways, cardioversion, pacing, IV access, any type of med that would deal with rate control or heart rate or NIC, and also to respiratory. So we ended up with almost 600,000 patients that presented with an abnormal vital sign. At least one abnormal. Now this won't add up to 591,000 because some patients had more than one, right? So SpO2 is up there, 282,000. Blood pressure, 100,000, almost 101. Respiratory greater than 20, 292,000. Less than 8, 15,000. Greater than 120, 125,000, and less than 60, 97,000. So out of that cohort, how many patients had more than one abnormal vital sign? One abnormal vital sign, 55% of the cohort, 35, 200,000 patients had 2, 51,000, almost 52,000 had 3, and then 3,100, 3,200 had all 4 abnormal vital signs. On presentation, first vital sign as we arrived. So what were the results? Well, as you might suspect, all 4 of the vital signs are critical. We call them critical, and I really wonder if we pay attention because we use the word critical a lot. Maybe we should call them important, maybe we should call them supercritical, whatever, these are critical. The model performance was 0.766, fairly good model. Not as good as 0.8, but we could create a better model, but this is pretty good. And also, time to our first intervention. So we're going to talk about the first ones first, and we'll talk about time and intervention because I can show you in a graph where we ended up. So we ended up with 7,576 arrests, 3,477 arrested prior to us getting there. So not a status patient, not much we can do with that. But we want to use that as a comparison. And then 4,099, almost 400, 4,100 patients arrested after we arrived. Respiratory rate, no surprise, 5 times odds rate, 5 times higher. Bradycardia, less than 60, 4. SpO2, 4. Low blood pressure, 3.5. tachycardia, 62% chance.
And these are odds of coding.
Yes.
So low respiratory rate, man, you had a really increased chance of having an EMS witness arrest. Same with bradycardia and hypoxia. It kind of mirrors what Vera Villani found from the folks in MedStar of their 30 cases.
So we're going to look at a couple curves. This is a Kaplan-Meier survival curve. Well, the cohort of those 591,522 patients, it took us an average of 10.5 minutes to do the first intervention. That's everybody. That's all 7,500 that arrested. 80% of the arrests occurred within the first 10 minutes. Sample mean here for the intervention is 5.1. And again, the 10.5 is for all 500,000 patients. You can see for these patients that arrested, for all the arrests, sample mean is 5.1. The ones that arrested before we got there, well, we move a little quicker, don't we? 3.4 minutes. And you can see at 10 minutes, we don't have too many patients left. You can see the sample mean at 4, at 3.5 there. Again, these are the ones that still takes us a little while to get going.
I think that makes sense though, because the vast majority of jurisdictions stay in play for cardiac arrest, but there probably are very few that still load and go, and that's probably why it's not, 30 seconds or 1 minute to intervention, but there are a handful that cause the mean to be a little bit longer.
And then these are the patients that we can actually interact with. They're alive when we get there. They have vital signs. And you can see the sample mean here. The first intervention is 6.97 minutes. You can see in the first 5 minutes, 50% will arrest. 50% of the patients are resting right in front of us. And it takes us 7 minutes to do the intervention. A BVM, an oxygen administration, getting pulse ox. 50% occur early in the first 5 minutes. Sure.
There was a slide from the woman physician had said that the least of interventions were vital signs prior to arrest. Patient deep, compromise. Is that true? No vital signs. Then you don't decide to break through it.
I think you were, was that, I forget, it might have been the Inez slide, or it was from Vera Villani, but I think that for their SADS cases, the least common intervention off the bat was vital signs.
Yeah.
Most common intervention, moving the patient to the ambulance.
Yeah, that's
Yeah.
right.
Yep. Yeah.
Really.
So here we are. These patients, they're alive in front of us, and they're going to code. And we need to know they're going to code, because they're going to code quick. So when we take a look at this, a forest plot of all the vital signs, the red is the abnormal, the blue are the normal vital signs. You can see how delayed we are. Bradycardia, tachycardia, bradypnea, and really surprising to me, hypoxia.
This is so interesting because we're intervening earlier on patients with normal vital signs, and then intervening later on patients with abnormal vital signs. It's got to be because we're moving them to the truck, and that's all I can think. You have someone with abnormal vital. Why are you intervening on someone, or putting on oxygen on someone with a SpO2 of 95, or giving a net to someone with an SpO2 of 95 before 85? It's got to be because we're moving the patient to the ambulance. I just don't know if there's another explanation for this.
And so,
People still like,
get them to definitive care.
If you do the heart rate,
Get into the
as an
hospital.
example, you know, if I hit somebody with heart rate of 162, that's my alarm. Same thing if someone's sitting there and says, oh, I don't feel good, your heart rate's 120, so that is what cause for concern.
Again,
It's not normal.
right.
To sit there with no, you know, no, you just can't move, you're sitting there for an hour and you don't feel it. So your heart rate's 120.
And I think again, it goes back to the old dogma. We still have that definitive care being at the hospital. Definitive care has been moved to you. Everything we do early in the hospital, we do out in the field. So we're rushing to the hospital to do in the first 10 minutes what they do there. It's on our trucks. On most of our trucks.
In our bags.
Yeah. So this is actually our distribution. So most of our patients had 3 vital signs. 11% had 1, 1,100 2, 1,500 3, and 812 or 21% had 4 abnormal vital signs. So what this graph shows you is that the blue are the patients that don't arrest, the red down at the bottom are the patients that do arrest. You're going to see that the patients that had all 4 abnormal vital signs, it still took us greater than 5 minutes to interact and do an intervention with them. Over 5 minutes. 32%, almost a third of the patients took over 10 minutes. And the arrest rate for these are 16 times higher than the patients with 1 abnormal vital sign. 16 times. If they got more than 1 abnormal vital sign, better be quick. And I can tell you one of the things I see all the time. When we're going to these calls, we're taking the monitoring, turn it on. There's half a minute wasted with the fire. No instant on time. Can't control it on the front of the truck, so you pull it out. We're walking in, it just go ahead and pop up the monster is ready to go. Again, the median here is about 7 minutes. And so for the whole cohort, it took over 70%, 5 minutes. For 7 minutes, 58%. And 43% were still 10 minutes to do an intervention. For all the patients. We don't know which ones are going to fit. We have some good idea, but we need to use some really good gut clinical visual acumen, our experience, expertise, and
when you're talking about time and measuring time, do you differentiate between outpatient time or vehicle arrival time?
This is all
we use
outpatient.
outpatient time. Which, for the most part, how many people just put 1 minute? Like, when I looked at all that data, which is 19 million records, I'm not looking at every one. But most of them are fairly, when we validated some of the times, they're usually a minute. Sometimes they take a little longer, right? We gotta walk, when we go upstairs, we arrive, we're running out there, and we leave the truck, we've arrived, click, goes onto our car, CAD import, but really it takes us 10 minutes to get up to our vehicle. And so sometimes those are there, so we didn't really discount. We did get rid of the minus ones.
Yeah, we removed a bunch of it, presumably erroneous data. I mean, like when your time of arrival was in the year 1900. Yeah, we excluded that.
No, these are ESO data times, so they're chart times. Can't tell you. That's one thing we can always say, it's always about the documentation, right? So this is what the documentation is showing us. But when you go into your shop and you evaluate your data, which you saw on the abstracts, it matches this pretty doggone close. So we have a tendency to think that, yes, there could be some discrepancy about documentation, but are we really off? I'll give you, we're off by 2 minutes. If you subtract that from 10, it's still 8, and the patients are gonna die.
It's definitely a limitation for the timed intervention piece. I think that still the vital sign and risk of arrest, odds of arrest, that speaks for itself regardless. There's no, it's not dependent on the provider input.
Yeah, across 19 million records. Yeah. And that's another reason why we wanted to do that, is because we really wanted to validate what we had done before, because it's COVID. We wanted to see what post-COVID looks like. So, we'll get to that, yeah, we'll get to that. Good question. Have we implemented any checklists, or have we made some changes? We have. We're still struggling. So even the sickest patients wait too long. This is the patients and their arrest rates over on the right-hand side. And you can see patients have 1, 2, 3, 4. You can see the arrest rate. And where you get the 5.6 versus the 0.36, that's where we get that 16% increase in 16 times arrest rate. If you look at normal patient vitals, it's actually double that. It's actually 32%. These patients will code 32% odds more than the patient with all 4 vital signs. And so what does that mean? So patients that have those 3 sets of 3 abnormal vital signs, roughly 80, so 78 to 84. The regression says that for every vital, you're going to have about 30%. 8 to 84. The regression says that for every vital, you're going to have about 30% increase. Intervene in those first 5 minutes. Respiratory cases, pulse ox, crew management, get that on there, treat what we see, check it back off of it, that's kind of okay. But respiratory patients are visual, should be visual, and we need to do faster. We just need to be faster.
All right, so we know that time intervention matters. SADS is a real thing. So how do we address this as EMS leaders? Well, like Steve mentioned, this has been drilled into our head. This is such dogma in EMS, load and go. Get them to definitive care. Like Steve mentioned, definitive care, such a misnomer. Those first 30 to 60 minutes of care in the ED that I'm going to do when I see the patient are the same as what you're going to do in the field. So we really need a reset. And how are some ways that we can have a reset? Well, first is implement crashing patient bundles. And there's several crashing patient bundles out there. I'll go through a few of them. The first is from down in Maryland at MIMS. And I love this one because this is on page 15 of the protocol. So right after the table of contents, they have this. They say, if you have identified a critically unstable patient, stop all movement of the patient, do not initiate transport, and go to their critically unstable patient protocol. And what does that look like? Well, the idea behind all of these crashing patient bundles is essentially the same. Cease all efforts at patient movement until treatments in this protocol are complete. So let's look at the one from Pittsburgh. I like this one as well. This one actually I think was adopted by all of Pennsylvania. The idea again is the same. Do not initiate movement of the patient. But they actually break this down by specific time cutoff. So within the first 10 minutes, you have to have electrical therapy, access, start your fluids. Within the first 15 minutes, reassess, start pressors if need be, so on and so forth. So I like having actual time cutoffs written into this protocol as well. This one's from Arizona, and again, the idea is the same for all of these. Initiate resuscitation prior to patient movement unless movement is necessary for safety or patient access. Austin Travis County, though, they took this a step further. They actually protocolized the minimum equipment that you have to bring to the patient side for every patient. I think this is so important because, yes, dispatch is pretty good, but it's not perfect. Has anyone been called to what seems like it's going to be a totally benign, easy call, not a sick patient, and then the patient's sick as not? Yeah, I mean, a few months ago I had a crew called out to an alpha sick call. The patient was in VT. They left all their stuff in the truck. They had to run back. They were kind of caught with their pants down. Had to go that get all their stuff from the truck, bring it to the patient. There's a delay in resuscitation. So you just don't know when you're going to encounter a critical patient. So I love this actually criticalizing what minimum equipment that you need to bring to the patient's side.
So that then, you know, to a BLS provider,
Okay.
or is it AUZ and
Perfect, thank you. Yeah, so we break it down by level. Their levels are different than other people's. Yeah, I noticed that. That's good. That's good. But I love this protocol. I voiced research. The reason why we carry things in bags, it's not to look pretty. It's not to just fetch the patient and bring him back to the ambulance. It's to bring the resuscitation to the patient. Maybe we need to take this a step further, though. Maybe we need to approach critical medical patients like we do cardiac arrest. Maybe we need to have pre-assigned roles and use a pit-crew approach like we do in CPR so that we can more quickly identify critical patients and initiate resuscitation for them. So what could this look like? This is kind of what we came up with, and of course this is going to depend heavily on your response configuration, but what we came up with here was kind of clinician 1 could be a BLS provider, clinician 2 could be an ALS provider. So clinician 1, first thing, do a pulse check, get vitals, initiate treatment of hypoxia and respiratory therapy, while clinician 2, the ALS provider, starts access, because presumably that's one of the things that takes the most time. And then they can switch to electrical therapy if need be, and then additional clinicians can fill in additional roles as they come in. I'm not going to belabor every point here, but just the idea of having pre-assigned roles so that we're minimizing time to intervention. Notice nowhere in here did I put 12 lead. Maybe it probably should be in here somewhere, but I think it's important to point out, one of my pet peeves is when we have someone who, we show up, our first move is to get a 12 lead, or we just got an SpO2 of 60, or we just got blood pressure of 60. What's our next move? Getting a 12 lead? Like, no. Our next move should be addressing that and resuscitating the patient, getting access, getting fluids, suppressors, giving oxygen, CPAP, whatever the case might be, not getting a 12 lead. Treatment and resuscitation takes precedence over diagnostics. I do want to point out this idea, however, of a SADS prevention checklist. So we developed this checklist to apply to medical patients who were hypotensive at any time, hypoxic at any time, requiring NIPPD, BDM, or advanced airway management, or had an arrhythmia requiring treatment. This is what the checklist looks like. Again, I'm not going to belabor every point, but I want to point out a few things. First, minimum 10 minutes time on scene at the patient. We've learned for post-ROS patients, we need to spend time on scene, stabilizing the patient, so why not do that for other critical medical patients? So everyone here stabilize on scene post-ROS? Everybody staying there? Okay. So why not do it for our critical medical patients? SVP at least 80 and uptrending, you want to see things going in the right direction. And what I tell my crews is, look, you don't have to have the patient a perfect 120/80 before you move them, but you want to see things heading in the right direction. Next, meaningful access. Clinically meaningful access is so important. If you have someone with a blood pressure of 60, a 22 gauge and a pinky toe ain't going to cut it. You need proximal, large bore access, both in terms of being able to get adequate volume in, but also making sure that the medications that you're giving are going to be bioavailable and reach the central circulation. Even if that means doing IO on an awake patient. I mean, if you have someone with a blood pressure of 60 and you fail IV access, probably move on to an IO. Is that a foreign concept to people? Everyone do IOs on awake patients? We do all the time. We do all the time. And when we first started doing that, it was kind of like, oh my God, I can't do it. Absolutely you can. Personally, I'd rather almost have an IO than be stuck like 10 times with the IV. Just get it done.
Can you go back one slide?
Yeah. This one?
Yeah, so I just want to see what it applies to hypotension, hypoxia.
Mhm.
Got it.
So kind of like definition of critical medical patients. One other thing I think is really important in this checklist is the idea of pre-positioned or predetermined stopping points for reassessing your patient during egress. Like I mentioned before, it always takes longer to move the patient to the ambulance than you expect. Having predetermined stopping points for reassessing the patient, titrating pressors, titrating oxygen, making sure the patient still has a pulse. I think it's really important for making sure that we don't have the patient decompensate while we are moving them to the ambulance. So what are some challenges ahead? Well, first, we have to differentiate trauma from medical. For critical trauma patients, yes, the mantra of load and go still holds. It's an operative disease. They need to get to the trauma center. Although that paradigm might change as more agencies carry blood, for now I'd say load and go still holds true. We don't want someone with a GSW to the chest and a blood pressure of 50 to have a crew saying, oh, I need to stay on scene, resuscitate before we go. No, please get that patient to the trauma center as soon as possible. So it's important to make sure your crews are differentiating trauma from medical. Next, what about those traditionally taught time-sensitive medical emergencies of STEMI and stroke? We've been always taught, oh, hey, these need to go, be transported right away, minimize scene time. I'll tell you though, based on my anecdotal experience, it's better to spend that extra time on scene resuscitating the patient so that you're preventing them from dying. I've always said, no one cares about dead STEMI or dead trauma patient or dead stroke patients. Your job is to get the patient to the hospital alive. I've had cases where crews are on scene, they have a STEMI patient, they're critical, they're hypotensive, they fail access, say, well, I gotta minimize on scene time because it's a STEMI, and then the patient codes because we didn't do anything to stabilize them. Unless you are working in a place that does intra-arrest CATs or ED ECMO, really our job is to get that patient to the hospital alive. And especially for stroke patients, I mean, for stroke treatment, we talk in terms of hours, right? Not minutes or seconds. So taking that extra time on scene to make sure a patient doesn't die is important. Let's face it, no one's taking a unstable stroke patient, rushing them to CT or neuro IR, right? They're going to stop the ED and be resuscitated before they go anywhere. Another challenge is this saying. Everyone's seen this saying, treat the patient, not the monitor. You know, I've seen paramedics time and time again use this as an excuse or a reason to not treat a patient's hypotension. And I think that this probably originates from a time when our monitoring equipment was not very good. Our monitoring equipment is very good now, and I'd encourage you to trust what you're seeing. It never ceases to amaze me how well the human body does, or how good the human body does at preserving blood flow to the brain, heart, and lungs at the expense of your other organs. So just because you're GCS 15 does not mean you're getting good blood flow to your kidneys, to your gut, etc. And what's the harm in going ahead and just treating them as if they are hypertensive? We don't want to miss an opportunity to treat the patient and have them decompensate. Worst case scenario, I mean, just get a manual blood pressure. Anyone in here work for a jurisdiction that requires manual blood pressure as part of the first vital signs? Yeah, Pitt County does as well, where we're from. So if you don't believe, get a manual blood pressure. So I asked AI to come up with some alternate sayings for that saying. I like these. The monitor never lies, your patient might, or the monitor sees what you might miss. So don't miss an opportunity to intervene on one of these critical patients. How about SpO2? Anyone ever, I love these AI pictures. Anyone ever come across someone with crazy nails, can't get a good SpO2? Yeah, all the time, right? And I see crews, oh, well, I couldn't get an SpO2, but they weren't complaining of shortness of breath, so I didn't treat it. But I asked them, what's the harm? Better to just go ahead and treat them as if they are hypoxic, so we're not missing an opportunity to initiate oxygen and have them decompensate. It's worthwhile to mention that there are other ways to measure SpO2, right? People have seen these forehead probes that we use in the ICU and in ED, but there's cool technology out there, ear probes, nose probes, etc. But again, what's the harm in going ahead and treating the patient as if they are yes, exactly, very expensive. Just use it, just treat them. How about that? Another thing I hear a lot is, oh, Dr. Bolin, I couldn't treat this patient where they were because it was too dimly lit, because it was too dirty, it was a hoarder house, etc. What I've always told my crews is that this is about doing what's best for the patient. It's not about our comfort level. Sometimes we need to get down and dirty within reason and resuscitate the patient where they are, because again, it's about doing what's best for the patient. There's a reason why we have an extra uniform with us at the station. There's a reason why we have showers. It's that we can treat the patient where they are, because yes, oftentimes we find patients in unsavory conditions. Finally, how far do we take this? Well, I live in the medical side of things, right? I'm an EMS medical director, but there's this whole operational realm as well. And like many things in EMS, it's a Venn diagram, and this falls in the middle of having both medical and operational implications. So there is a huge operational cost here, right? Because by my asking my crews to stay on scene longer, our ambulance turnaround times are going to increase, right? So how do I get buy-in from this from the operational folks? This is what I tell them. This is what it's all about. There's no worse feeling in the world than having a patient die on you, knowing you did nothing to prevent the patient from dying in the first place. That's what it's all about. It's all about saving lives, preventing patients from dying. So future directions, how long do we stay on scene? What are good vital sign cut points where we feel the patient's stable enough to move them? How about trauma patients? Is the notion of load and go going to change as more agencies carry blood? And how about those traditionally taught time-sensitive medical conditions of stroke and STEMI? Should we still load and go for them? Of course, my anecdotal experience is no, we should resuscitate them, but probably some literature and some data to back that up would be great. So load and go is dead. We need to stay in play for these critical medical patients. I'm going to turn it over to Steve to give a few last minute thoughts.
All right, a few takeaways. So, patient critical vital signs wait too long before they get interventions. 10.5 minutes. 50% of our patients arrest in the first 5 minutes. Take it home. So key takeaways: clinical acumen, sick or not sick. We see patients size up as we approach, get your vitals early, develop a pressure patient bundle, treat the abnormal vitals and stabilize before transport, and for all means, bradypnea, bradycardia, hypoxic patients, patients with 3 or more abnormal vital signs are an immediate priority. And remember, Dr. Olu talked about it earlier, physiological instability will accelerate faster than we'll think it does. It'll accelerate the timing as we exhaust those compensatory mechanisms. They can compensate. But you add hypoxia to it, as soon as they go down that curve, they crash. Leave this up for a minute. This is where you can get, can't get this slide set yet, it's not up. But you can get all the literature, all of our lit reviews, and everything are on that QR code.
That's all I have. Thank you, everybody.
Hey, don't forget to shoot your capsine back. Yeah, we don't. They didn't.
Yeah, they didn't put it on.
Perfecto, súper bueno muchachos, esto estuvo excelente, esta clase.
Can you go over the cutoffs for